2/3 of our hospital beds are occupied by people aged over 65. If we can get it right for older people, essentially we can get it right for the NHS.
Welcome to Health in Hyperdrive, the podcast where we explore the breakthroughs shaping the future of healthcare. I'm Dominic James, and today I'm joined by Professor Jugdeep Dhesi, consultant geriatrician at Guy's and St Thomas's and Professor of Geriatric Medicine at King's College. Jugdeep is also president of the British Geriatric Society, where she is helping shape national policy and practice for an ageing population.
Using AI to generate us an output for that individual patient that illustrates their needs from a medical, functional, social, psychological point of view.
Jugdeep, welcome to Health in Hyperdrive.
Oh, thanks very much, Dominic.
So maybe a really great place to start is, I think it's really well known and well publicized that we have an aging population. What are the sort of the facts around that, and how does that impact the health system?
Yeah, Dominic. So I think, for years now, we've been hearing about this tsunami of older people, haven't we? And often that's kind of termed in a really negative way. But of course, it's down to the successes of health and social care that we're seeing people living longer and living well as well. And that does now mean that we've got about 12 million people in the UK aged over 65. But of course, the issue with aging is that you accumulate issues as you get older. So the impact of your social determinants of health, so education, housing, nutrition, smoking, alcohol, sedentary behavior, that affects how well people age. And then alongside that, we have physiological change. So sadly, even if you're a fit 80-year-old, you're not the same as a fit 30-year-old. But the other thing that also happens as people get older is they get more and more medical conditions. So we often call that multiple long-term conditions. And we know that half of over 65s are living with at least two coexisting conditions. And by the time that you get to the age of 75, you're going to have at least three coexisting conditions. So you have these multiple medical problems going on, which often then mean that you end up on lots of different tablets as well. And alongside that, there's the geriatric syndromes that start to appear as people get older. So things like frailty, dementia that we hear quite a lot about in the public press. And it's really that kind of impact of all of those things that means that older people are now the biggest user group of health and social care in the UK, but across the developed world as well. And we see that playing out in real life in that 1 in 3 older people are on at least one waiting list. 40% of our emergency attendances at hospital are older people. 2/3 of our hospital beds are occupied by people aged over 65. So that's got a real impact on the way that we set up and deliver health and social care now, but also for the future, where we know we're going to have an even more aging population.
And it's a really personal topic because, I mean, if you're lucky, you get to that stage, and it's inevitable for everyone. Like most disease areas, of course there are common things. Cancer, 1 in 2 or 1 in 3 people are going to get cancer in their lives, but aging is happening to everyone. We're all going to kind of arrive there at some stage if life goes well for us, in fact.
That's right.
So it's a very personal thing in that respect, but then also everyone has sort of elderly people in their family.
Yeah.
And so it's something that we all kind of live with, and it's one of these kind of health areas that's very familiar on a very personal level. It's interesting. You're a geriatrician, and there are health is largely around specialisms, and it's one of the sort of the few areas, I guess, pediatricians is similar, and then lesser so. There are some specialisms in different stages of life. But could you explain a little bit around what a geriatrician does and what's the reason for it? I think you started to just go down that path anyway.
Yeah, no, that's right. And I think it is very personal to all of us, as you've just mentioned. And so I suppose there is kind of work there that we need to do to support our population to age well. And that, of course, starts from the womb, really, where we've got to get nutrition, vaccination, education, housing, such that we do support the wider population to age well. But in terms of kind of what a geriatrician actually kind of does, I think lots of people are often surprised actually to hear that geriatric medicine is the biggest medical specialty in the UK now. So the number of geriatrician consultants actually outnumbers lots of the organ kind of specialty doctors like kidney doctors or lung doctors. So I think that it often goes under the radar that actually there's a whole group of people who are very much specialised in looking after older people. And so, yes, what do they do? So there's a whole range of jobs that geriatricians do, from community, primary care, and into secondary care. But the underlying issue is that they're supporting people with that complexity. Those social determinants, those physiological changes, those multiple long-term conditions, frailty and dementia. And what they're doing is using a structured approach to help to assess where a patient is, diagnose lots of conditions that actually go missed in older age because we just put them down to being part of normal aging. But once they've diagnosed them, using our general medical skills to optimize people across that range of conditions so that you don't have an older person going to one specialist and then another specialist and then maybe a third one and accumulating medicines that actually have side effects and interactions, and that we end up losing sight of what actually matters to the individual patient and treating the patient, more importantly, rather than the condition.
Can I ask just like I've got some basic questions, so
Yeah, of course.
maybe a little bit personal. Of course,
Yeah.
I've got aging parents. I won't call them elderly because they won't like that. But aging parents. Let's put it like that. So, for example, what's the difference between my parents, say GP, and their geriatrician? Or I think I'm not even sure that they have one.
Yeah. So most people won't routinely have a geriatrician. So this is considered a specialist opinion. So you're absolutely right that general practitioners do lots of work with older people. They do assess and diagnose. But sometimes these conditions are actually quite complex, and putting them together requires that specialist knowledge and skills, lots of kind of pulling together of literature around what do you do for a cardiovascular condition when someone's also got Parkinson's disease. And so it's in some ways it's the same as what general practitioners do for heart disease, in that of course lots of heart disease is managed by general practitioners with medicines and starting the right treatments, but then when they need the specialist opinion, then they'll refer to a cardiologist. And that's the same for this as well, in that you can do a lot of the basics in primary care, which is done really well up and down the country. But then you need that specialist review to help to make those decisions around sometimes the diagnosis. So diagnosing dementia isn't always straightforward. Distinguishing that from depression or other endocrine conditions sometimes requires a little bit more of a specialist review. But then deciding about what treatments to use in that situation and how to put that together for that individual patient.
And then is this, different health systems around the world are obviously different. Is a geriatrician a standard profession kind of across the world, and do they do similar things? I know you work on a global basis.
Yeah. No, so it is really interesting as to what's happening internationally. And certainly the UK has had a very strong history in geriatric medicine. So it was founded as a specialty 80 years ago. The first geriatric medicine society, the British Geriatric Society, set up here in the UK. And certainly internationally, it's us that everybody looks to for support in developing age-attuned services, the research, the education and training. So we're certainly leading the way in clinical geriatric medicine. But lots of other countries do have a very strong basis in geriatric medicine, but it is very variable across even Europe, in Australia and New Zealand, places like that where they've actually modelled a lot of their healthcare systems on the UK system. There's a strong geriatric medicine focus. I think it often relates to whether systems are publicly funded or privately funded. And so in the US, actually, clinical geriatric medicine isn't as strong as here because people, kind of the way that funding works, you're more likely to still want to see a cardiologist and a respiratory doctor and a renal doctor because they're also looking for their business around that as well. So certainly the way that a healthcare system is funded does influence it. But recently, we've had lots of requests from the developing world as well. So certainly from India, from Pakistan, Malaysia, and particularly from China, because of course in those populations, they're also seeing that tsunami of older people. And of course, the working age dependency ratio, particularly in China, causing real concern for them for the future. And I think, some of the stats from places like that are so interesting. 400 million people aged over 65 in China.
Yeah.
It's the total population of Europe.
I know.
And so we're doing some work kind of hopefully with China to support the development of geriatric medicine there too.
And I think, those kinds of numbers, the fact that the population is aging, and also the way that medicine is structured around specialisms, and we're going to have to do with the volumes of people kind of reaching an older age, we're going to have to do some very different things. That's really the reason why I wanted to have kind of this conversation with you, because, in some respects, we're going to have to find technological solutions to some of these things.
Yep.
And also a little bit the direction that, I don't know if this is true, the direction that medicine's going. That what technology is now enabling in medicine is when you look at kind of AI, and so the reason why we have specialisms in medicine is because it's so complicated. So you need experts in each of those fields.
Yeah.
What AI enables us to do is to kind of look at data across and come to some kind of conclusions across multidisciplines. And so in some respects, I feel that while we'll always need specialists, a cross-discipline approach is really going to be somewhat the future of medicine enabled by technology. And it's going to be necessary for geriatrics. I don't know if that kind of makes if that resonates with you. I know it might make sense. You might not agree with that.
It completely makes sense, Dominic. So I think there is a clear need for that cross-disciplinarity at the moment, whether that's within medicine itself, or whether that's between healthcare and social care professionals working with industry and with other partners to be able to deliver that kind of joined-up approach, which is what patients tell us that they want. They want, every time that you do any patient public-facing work, they consistently tell us that they want to have joined-up, seamless care that's holistic, focusing on what matters to them, and that they want to have a single point of access for communication. So loads of studies telling us that across different specialties and areas.
And that's kind of universal, right? Across,
right.
Regardless of age group.
Exactly,
So,
that's right.
I sort of feel like in some respects, you in your profession and expertise is really a little bit the future or the direction of travel, let's say, where things are a lot more kind of integrated and kind of coordinated across.
Yeah. No, I love the fact that you're kind of saying geriatric medicine is the future.
Well, it's going to be my future, that's for sure. I hope. But no, I'm involved a lot in health tech, of course, and quite a few people who are kind of at the cusp of this, more expert than me, physicians. A lot of them will say GPs. The profession of GP is going to be really transformed through technology because, while it's very hard for a GP to know everything in detail, with a lot of the technology, they'll be a step closer and be much more informed.
Yeah.
And, I feel that's also the same with geriatrics, except I guess you're kind of already doing that, but you're kind of a lot more specialized, and then the community and the social care and all of these other things are all sort of in your wheelhouse as well. And these are things that are kind of well understood, not necessarily well solved for, but kind of the problems I think are well understood in your kind of area and your discipline.
I think that there's been, lots of work done on understanding the problem, and we do understand kind of, what patients want, what we need our services to deliver. And it is now about how we use new technologies to be able to deliver that efficiently and well. And I think that's really where we do need to focus now, on co-producing kind of ways of us collecting data for patients that is real time, can help to describe those medical, functional, social, psychological problems that people are facing, but collecting data in a way that's meaningful to patients, easy for them to do. And then being for us to be able to use that data to be able to shape the services that are required. And we're working very closely with general practice on that, because of course, we absolutely believe in the kind of the general practice being the holders of things that are going on for an individual patient. They need the right information coming into them so that they can then look at what can be delivered in the community, maybe through neighbourhood health teams into the future, but then knowing how and when to refer on to the specialists as and when needed. And then the work that we've been doing there about where we add value has been looking at different parts of that patient's kind of journey. And we've been doing some work with general practitioners around how they can just, call us for advice when they've seen somebody. So rather than necessarily sending them in for an appointment or sending them to the emergency department, they actually give a geriatrician a call, say, this is the issue I'm worried about. What are the options here that would be right for this individual patient? So simple stuff like just picking up the phone.
Yeah.
But then also having things like hospital at home services where the GP can talk to us and we can say, actually, we think this patient can be managed at home, but we need to come in with remote monitoring, be able to give blood transfusions, fluids, antibiotics in people's homes to avoid those unnecessary admissions into hospital.
I'd love to, I really want to talk a lot more about all of those things. I'm thinking maybe before we kind of go there, let's have a little bit. I'd love to learn a little bit more about you, your personal journey. How did you get into this? Why did you choose it? What was your journey?
Yeah, no, that's kind of it certainly resonates that comment. So I grew up in Essex, went to Leicester for medical school, stayed up there for my house jobs and SHO jobs for the first 3-4 years after qualifying. And at that point, I'd actually been offered a job in neurology, specialising in neurology and in endocrinology. And I had 6 months when actually I could do some travelling before I came back to take up either of those posts. And it was while I was away and having a little bit of distance from kind of, that treadmill that I'd been on, that I started making some lists about the things that I really liked about medicine and the things that I didn't like about medicine as a career. And as I started to add that up, it became really clear that what I liked doing was putting the puzzle together around an individual patient, looking at all of the different health issues, but then the interface between physical and mental health, health and social care, fiddling around with people's medicines and kind of deciding which ones were the right ones, which weren't the right ones, thinking about how I used evidence to inform that decision-making, but how I brought that back to the individual patient each time. And so it was a little bit of an epiphany, actually, that I suddenly came back kind of thinking I'd ended up going down the path of neurology and endocrinology because I'd had amazing role models in those fields and I just wanted to be like them. But I'd actually lost sight of what actually made me tick. And so I came back after travelling, completely decided to move away from Leicester, applied to London, came down here to do geriatric medicine. And it was funny because my husband, my boyfriend at the time, kind of said to me, but you hated your geriatric medicine attachment. How come? And I think it was because actually I didn't have the role models there to show me how it could be exciting and interesting and value adding. And that's what we're now working really hard at, is kind of demonstrating to our medical students, to our FY1 and 2 doctors, as to why this is the future.
Yeah.
And of course, just going back to those stats, actually, essentially, wherever you work, unless you end up doing pediatrics or obstetrics, you're going to be doing geriatric medicine. So it's really important to kind of have some grounding in that, whatever specialty you end up then going into.
So it's a really interesting point, and I can only this personal story you told there is a familiar one for me. I think, medicine's, I've learned this a little bit. Medicine's an interesting career in that respect, because you go down a path and suddenly you have to decide that I'm going to specialize in X, Y, and Z. I don't think there are any careers where you have that, that I can think of, that you have that really hard decision at a point. And, just through your career, just in more general terms, the people you work with make such a big difference to how you feel about the work that you're doing. So probably that's just good advice to take a step away and try and make that separation, and kind of anyway, because it sounds like you're a very mature young person in your thinking. And then, so you're also an academic and a researcher. Can you talk maybe a little bit about the difference of being a clinician versus an academic, and how did that kind of progress?
Yeah. So when I came down to London for my specialist training in geriatric medicine, I'd expressed an interest in doing some research, and then had an opportunity to apply for a PhD looking at the effects of vitamin D on neuromuscular function. So very much kind of slightly basic science, but also a clinical kind of trial. So that was my I did 2 years full time on the PhD, and then carried on part time whilst I went back to my clinical work, and found that I really enjoyed the research side of things, but that I wanted to keep any research that I did grounded in day-to-day kind of patient-facing work. And so I did make a choice to actually remain as an NHS clinician, so full-time clinician, but doing research on the side. And there are different routes, again, for that in medicine, either going down the formal academic route and being a university-employed clinical academic, or being a NHS employed. And so I decided to stay in the NHS. And that's partly because I think it's so important to be on the shop floor, to see what kinds of problems patients are facing, and then look at designing clinical studies that actually answer those questions. And that's what's really happened over the last I've been a consultant nearly 22 years now, has been that my clinical work, working in surgery, so improving outcomes for older people having elective or emergency surgery, has really informed any of the research that we've done as a department. And we've been very successful at that, in terms of becoming known now as the Centre of Excellence for Perioperative Medicine internationally. And that's helped us both to build up our academic kind of reputation, but also to use that to inform clinical services and national policy as well.
Can you just say what is perioperative medicine? I had to Google it before. This is my story of doing a podcast. There's a lot of Googling involved, especially in healthcare. But could you explain what it is? You'll do a better job than I will, for sure.
Yeah, no, thank goodness for Google, hey. So perioperative medicine is really just thinking about the whole pathway. So I suppose lots of people would think about it being the surgical pathway, but really thinking about from the moment that we start to think about surgery being a choice for a particular patient with a particular condition. So from the contemplation of surgery through the pre-assessment, optimization, the decision-making, then through the surgical period itself in hospital, through rehabilitation and out to the community. So it's that whole pathway that we talk about being perioperative care and perioperative medicine.
And for older people, that's of specific concern because...
Yeah, so it's a specific concern because actually the worst outcomes that we see after surgery are in older people, whether that's from a patient-reported perspective in terms of their satisfaction or their experience of care, whether it's from a clinician-reported perspective when we're looking at complications in hospital or afterwards or mortality, or whether we're looking at it from a healthcare manager's point of view, where we see that older people having surgery are more likely to be cancelled later, stay in hospital longer, have more readmissions, and therefore they cost the healthcare economy more as well. So because the over 75s are actually the fastest growing cohort having surgery, and yet they continue to be the group who have the worst outcomes, that's why we think it's really important that we focus in perioperative care on older
It's
people.
really important. It's really important for them, and it's really important for the system as well.
Yeah.
And then you're president of the British Geriatrics Society. What does that mean? Well, what is the British Geriatric Society? I think I know, but what does it mean being president of that, and how's that different from your other roles?
Yeah. So the British Geriatric Society, founded almost 80 years ago. So next year it'll be 80 years. So it's a multidisciplinary 4-nation society with coming up to almost 6,000 members. So the biggest medical society specialty, biggest medical specialty society here in the UK now. And I've been president now for a year, president-elect for 2 years prior to that. And the mission at the BGS is to improve health care for older people. So pretty straightforward. But within that, we have lots of different work streams to address that. So ranging from education and training, workforce, clinical quality, research, and policy. So those kind of 5 arms all kind of working together to be able to improve healthcare for older people. On a personal level, of course, it's a real privilege to be president of this kind of society. So first Asian background woman to hold that role. And it's an elected role, so it's really nice that our membership out there has recognised me as being able to provide leadership for the society for these couple of years. What's it mean on a day-to-day basis? So it is very different to being a clinician, but of course I bring all of that clinical experience, expertise to that role. Lots of working with wider partners in healthcare, so certainly with policymakers, Department of Health, NHS England, Scotland, Wales, with regulatory bodies like CQC, the GMC, but also with the colleges, the Royal Colleges up across the 4 nations, at really trying to make sure that we do keep a focus on the care of older people. Because, we strongly at the BGS believe that if we can get it right for older people, essentially we can get it right for the NHS, because that's where the complexity lies, that's where the cost lies. So lots of work with each of those partners to keep that momentum up.
What would be sorry, and you don't have to answer. In fact, this is probably your day job. But what would be a sort of an example of a policy area that would really impact elderly care? That you'd want to want to change.
So essentially, I think in some ways, there's no policy area where we don't have an impact at the moment. So we are, and I think that's part of the challenge for us at the BGS, in that it's a voluntary organisation, and so lots of people doing lots of work in their own time. And you could get involved with a multitude of different things, from that life course approach at supporting pregnant women to eat well, remain active, keep their blood pressure under control to get the best start for an individual to then allow them to age well as they get older. But we do have to keep a focus on exactly where we're where we can have our limited resource. So, recently we've been working with NHS England on the first 72 hours of care standards. So this is when somebody comes in through the emergency department, what should happen for every individual as they come into that ED to be able to triage appropriately. So how do we identify the older person with frailty and dementia quickly at the front door, signpost them to the right service, get the right specialist seeing them quickly, so that either we can get them home directly or admit them to the right area of the hospital. So that might be one example. But of course, we're also doing work with the Department of Health around the 3 shifts. that analog to digital, which may be really kind of relevant to lots of your viewers, but hospital to community and disease to prevention. And again, lots of things there that resonate absolutely for us.
Yeah. I mean, when this podcast is really about the future of healthcare, and actually all of those like a sort of digital or AI and analog to digital, that's just in my mind a how.
Yeah.
The sort of trends just broadly across are always around kind of earlier diagnosis, prevention, treatment outside of the hospital environment. For sure, there's kind of efficiency and productivity for clinicians. There's patient enablement, and then there's data that kind of cuts across this whole thing, and then kind of social determinants and increasing accessibility. So all of those are those are all topics that I that need to be solved, and will are being solved for with technology in my world. What's what's kind of the status of kind of geriatrics? Maybe what are some of the recent advancements in, say, the last couple of years, or the things that you think are interesting or exciting? For sure, there's a lot to do, and nothing is perfect. But there must be, what are the sort of the encouraging and exciting things?
Yeah. Gosh, again, there's just such a lot, Dominic. So there's lots of very nice studies around the preventive side of things. The recent studies illustrating that it looks like having a shingles vaccine reduces the risk of developing dementia. And the initial studies are looking really positive around this. And so I think, and there's one ongoing large study at the moment. So we're really looking forward to seeing the results of that and then seeing what we do with that. So, but there's lots of basic science going on around longevity and around vaccine use.
Yeah. Could we just talk about like that one, for example? It sounds a bit like random, I suppose, to a layman. I'm sure there's probably some science around that. But like, how do you kind of uncover something like that? I guess the fundamental is like data is a really important thing there, and being able to kind of understand, interpret, and having connected data in the first place, but then being able to analyze that and come out with some kind of inference or indicator, and then there's an investigation off the back of it to make sure it's a real thing. Am I thinking about that the right way?
No, that's exactly right. So I think, lots of these studies, when they first start, collect lots of data on a small group of patients. That starts to give that kind of signal. It is really important that we've got researchers who are looking across that breadth of kind of possible outcomes for individuals, but then picking that up and then thinking about how do we actually test this on a larger scale. And that's where we think it's really important that we start to develop platform studies where we are collecting real life data on all of our patients, people across the country, that can then help us to answer these kinds of questions. And it makes you wonder, how many things have we missed by not having collected that kind of data over time? So, I think this gives a really nice illustration of the need for that cross-disciplinarity in research teams who are able to pick up on those signals, but then informing the way that we set up studies. And I think we do need to move away a little bit from this kind of thing of RCTs, randomized clinical trials, being the gold standard for everything, because often they don't work in the real world. And that's probably why we've seen this implementation gap over years, where we find something out and then there's a 17-year kind of gap before it actually gets translated into clinical practice for the population at large. So I think we do need to develop research which is more proactive, real time, that we can then look at the findings and start to think about what we do with that on a population basis.
Yeah, and I'm going to jump back a little bit because I probably took you off track. Like, now I'm curious about shingles. Like, what does that mean from how far are we with understanding that as an example? I know you were just giving an example, but like, how far are we from understanding that, and what's the well, what's the impact? As you know, someone I have family with who've suffered dementia. I'm sure most people do.
Yeah.
But like, what does that mean in sort of real terms? And what's the outcome from that? I suppose if things go well.
Well, of course, the shingles vaccine is now available to kind of everybody over 75. So it's important that people are taking up that opportunity already. What it means in the longer term, I think, is that once we see the results of these larger studies, we'll then be able to decide about the age at which we think that it will be worthwhile us actually promoting shingles vaccines kind of at a younger age to even prevent that longer term kind of impact. And it sits alongside all of the other lifestyle interventions that we need to be pushing hard on to prevent conditions such as dementia.
And I probably took you off track a little bit. What are some of the other things that you find very encouraging at the moment?
Yeah. So I think some of the other really encouraging things is the use of data in the community. So we've had a really nice work done by the Leeds group led by Andy Clegg, looking at the electronic frailty index. So using patient data in primary care to be able to identify people living with frailty. Because once you start to do that, then you can start targeting people early with the right interventions and talking to them either about the frailty that they have developed and how better to live with that, or identifying them early in that pathway and then supporting them to make changes that will hopefully delay the onset of frailty and the longer term consequences of that. So I think that work has been really important. And what I'd really like to see with that now is kind of working with, people in the tech kind of partners is looking at how we use that kind of information to then co-produce interventions that really work for older people. What we still continue to see is that older people are often excluded from the development of those kinds of products for a variety of different reasons. It's not that people necessarily set out to exclude them, but maybe they, don't have access to digital tools. Maybe their internet coverage is poor. Maybe their sensory impairment limits them. Maybe their literacy impairs their participation. But we absolutely have to involve those groups if we're really going to see the benefit of these kinds of remote technologies that can support people to be remotely monitored as they wish to be, but also to then enable them to take up the evidence-based interventions we know can make a difference.
Could you, when we spoke in kind of preparation for this conversation, you shared a little bit about the frailty index. I had something in my head. I don't know why. I always imagine physicians with checklists and saying, do you do this? Yes. Do you do this? No. Do you do this? Yes. Okay, your score is 50 and you are frail. But that's not how this is working, right? I guess electronic is the operative word here.
Yeah. So this doesn't work that way. This is from the data set.
And correct me if I've characterized medicine in the wrong way as well.
No. That's but I think it is about how we mix and match these kinds of tools. So I think it's useful to use things like the electronic frailty index directly from patients' notes. But at the same time, it's also really important that our district nurses, admiral nurses, other community workers who are having contact with patients also do still use a checklist type approach to work out what might be going on with the patient. Because of course the EFI is going to be based on what is in the notes.
That's true as well, right? You need to collect the data, but the frailty index essentially goes through patients' notes and then creates a score on whether they're likely to be frail or at risk or need further investigation. And I as you describe that to me, I'm going to go back to the topic of AI and data. I feel that paints a really good picture of what the future could look like, because there's a lot of pots of data sat in a lot of different places. Connecting the data is really a challenge, and also collecting the right data. And it's not just medical data; it's also like lifestyle data and other types of data. But that's one thing, and then the next thing is what do I do with that? And the world is littered with big data sets that no one's able to look at, and I think that's where AI could play a really incredible role in analyzing and interpreting large volumes of data and helping us ask and answer questions off the back of that. Do you kind of see that opportunity the same way? I know kind of AI is not the magic tool because there's a lot of systemic things that need to be fixed before you can use it. But do you see does the future look like that in your head?
Yeah, no, it does. And I think, of course, it's not the magic tool, but it is a tool, and we need to learn to use it as effectively as possible together with our patients. So that's exactly how I would see it, is that we could use ensuring that we're putting in the right data. So that's the first bit, is just making sure that older people, geriatricians, are involved in making sure we're collecting the right data. Then the next bit is about using AI to think, really what we'd like it to do is to generate us an output for that individual patient that illustrates their needs from a medical, functional, social, psychological point of view. And that's what we tend to call comprehensive geriatric assessment, because then that helps you to work out what interventions we need to deliver across each one of those domains. And then we can think about remote kind of technology, patient enablement to address those interventions. So I think, that's why the role of doctors is going to change a lot, isn't it? Is to kind of, I think we're going to become much more at the kind of receiving the information to then inform the interventions and have those conversations in a meaningful way with patients and their carers.
You talked a little bit about kind of remote care. That's really interesting. When we started the conversation, you said I've got this wrong, I'm sure, but like something like 40% of hospital visits or hospital beds are taken up by elderly people. So people being treated at home versus in a hospital setting is both potentially cost efficient for the system, but also much better because no one wants to really be in hospital unless they need to, right?
That's right. So I think, there's always a bit of a fine balance here where we absolutely don't want to end up denying hospital-based treatment for older people by just saying that, we want to treat as many people at home as possible. So it is a balance about making sure that we are kind of making sure that people can come into hospital when they need to access treatment, but when they don't need to, that we do provide it in their own homes, because as you say, that's what patients want, and because it's cost effective as well. So that's really where services such as Hospital at Home have really come into their own, where we're able to deliver hospital level care in people's own homes by using remote kind of technologies. We've had virtual wards where we can actually see what's happening with patients on a day-to-day basis, but then also going out to their homes to deliver that care there.
Could you bring that to life just a little bit for me? What does it feel like from a patient perspective and also from a clinician perspective?
Yeah. So an example might be a patient who has known heart disease, who's becoming more breathless, getting more leg swelling, and they need to have some medicines to be able to get some of that fluid off. So kind of that's how heart failure often presents. In the past, what we would have always have done would be to admit a patient like that, because we wanted to monitor their renal function. So we'd want to take the fluid off, but as we take the fluid off, they can get dehydrated. If they get dehydrated, then their kidneys can deteriorate. So normally we would admit them, give them those kinds of treatments, monitor their kidneys. But of course, the issue with older people coming into hospital is that we know that they're at risk of hospital-acquired complications as well. So things like delirium, so acute confusion, or deconditioning. So when people lose muscle because actually they just end up sitting around in hospital rather than walking about, or even kidney injury, which we know is a hospital-acquired complication. So we want to try to not admit that group. So the way that we would do that now is that patient, for example, the GP might give me a call and say, actually, I'm worried about this patient. Their fluid status is worsening. What shall I do? And I might say, well, actually, let's give them some diuretics to get rid of that fluid. And the GP says, well, kind of we're going to struggle because of kind of their renal function and so on. So then I would ring up the hospital at home team and say, can you go in, give them the intravenous diuretics, but also check their bloods and make sure that we're getting their kidney function every 2 days. And then that information gets fed into our system so I can track it. It's sitting in the hospital and seeing what's happening with their blood pressure, their heart rate, their fluid status, their kidney function. And so by doing that, we can keep a person in their own home, mobilizing as they would want to, being more comfortable, getting some sleep, because of course in hospital, you know, it's noisy and difficult to sleep. So that's the way that we would bring that kind of situation to life.
I mean, like intuitively, that and from personal experience, you know, that has to be beneficial. You know, on being a family member of you know, of elderly people. You just it's not just them, it's also, you know, everyone rallies around.
That's right.
The disruption just across both the patient and the family surrounding them is massive. And
It is.
you know, if people are at home, that can you know, help a lot of people as well as the patient. Are there any like is there any sort of data or evidence that says that's a really great thing?
Yeah, no, we've got really nice studies about this, actually, Dominic. Showing both that it is clinically effective, so hospital at home services being clinically effective at improving outcomes, but also being cost effective. And so some of that work's been done by the UK Hospital at Home Society that we work very closely with from the BGS. Particularly by people like Rebecca Schiff and Shasha Shepherd, Sheila O'Riordan. So lots of really nice work, and particularly in remote areas as well, like in Scotland and the islands as well, where kind of this really helps for exactly those reasons that you've described. Is of course this is a real burden on families as well when you're having to travel, you know. In London, it's difficult because of public transport issues, but if you're in a remote area or even down at Darrant Valley in Kent, if you're 80-something yourself and your 80-something-year-old husband or wife is in hospital, getting a couple of buses to go in and visit every day is kind of has detrimental effect on the carer's health as well. So there's lots of nice evidence showing how this is beneficial clinically and from a cost perspective.
And then from a physician perspective, like, sorry, a clinician perspective, like how, like, does it lighten the load for you, or is it like just what's your experience or you know, your colleagues' experiences?
So I think kind of what kind of my colleagues kind of who work in hospital at home services tell us is that, of course, it brings a lot of job satisfaction because you see people looking happier and well in their own homes, and we're delivering outcomes that matter to them. In terms of lightening the load, I don't think it necessarily lightens the load. It just changes the way that we're delivering those types of services and making them more age-attuned, more patient-centered. But I think what we're starting to see is that we're having more and more roles which are part community and part secondary care funded, so that then clinicians can move between the traditional boundaries between community and secondary care more effectively, use the IT systems better, but also not lose that kind of support that you get when you're based in a hospital, you know, that team support. Whereas if you end up becoming a lone worker out in the community, that can be quite isolating and quite challenging. So we're really supportive, particularly of roles which are more fluid between community and secondary care.
And the nature of, sorry, I'm going to ask a couple more questions. We can maybe keep this a little bit short. But the nature of the people who work in hospitals at home, are they it's more kind of nurses, or it's
no, it's a real
doctors,
combination.
like
A real combination. So we've got lots of great geriatrician consultant colleagues who work between the sectors, but of course that's supported with a multidisciplinary team with nurses and particularly advanced nurse practitioners who have examination skills as well as prescribing skills. So it's also looking at how we really use our workforce as efficiently as possible, with everyone working at the top end of their skill set, rather than it necessarily being a doctor to go out to do some bloods, which doesn't need a doctor to do that. So we're really trying to make this the most efficient model that we can, whilst making sure that our workforce is enjoying what they do, because that's critical to retaining the workforce.
And can we just talk a little bit about technology here as well? Like, often you hear that technology can be a bit exclusive, especially when it's older people or impaired people, that that folks are not all. Some folks are struggling to use phones and apps and all of these types of and even sort of devices, wearables, all of these sorts of things.
Yeah.
What's your sort of view or your take on that? Is it they're right for some people, they're not right for others, or they need to be designed for the situation, or the end user is not necessarily, like, the person at the interface is not necessarily the patient, it might be the care team surrounding them. How do you sort of think about that as a topic? It's probably quite a broad topic.
Yeah, no, it is a broad topic. And so we have been doing some work looking at literacy, health literacy, digital usage amongst older people. And of course, there is a whole kind of spectrum of kind of where people are at in any of those particular kind of aspects. And we have people who are very tech savvy, into their 90s, using these tools very effectively. But I think you touched on a really important thing here, which is that any of these things that we develop need to be developed together with the end user. So if you're developing a tool that we're going to use in a rural community, then we've got to work with older people living in that kind of community to see what actually works for them. Do they have sufficient connectivity where they live to actually even be able to use these things? Do they have the dexterity to be able to input data in a meaningful way? But also end users in terms of healthcare professionals as well. So often we end up getting given something that we then have to learn to use. And we're just like, well, actually, this isn't really helping us in the way that we wanted it to. So I think that's the important thing, is getting the right end users working with those teams early in the pathway to make sure that we're developing things that really work in day-to-day practice.
I think this maybe brings us on to the topic of the future, and it's predicting the future is some people say it's a fool's errand, but I think we could see maybe some sort of directional trends. I'd love to kind of imagine a world, say 10, 15 years from now, seeing some of the things that are happening, some of the trends that are happening, and maybe kind of imagine what could the world look like for both patients and physicians in, say, 10, 15 years time. Like, what do you see? I'll find a crystal ball or something.
So, I mean, generally, I'm pretty optimistic. And I think we've got lots of opportunities at the moment, and we've got to rise to the challenges that we have. And it doesn't mean that we shouldn't describe the challenges, but we've got to look at the solutions. So I would hope that in 10 or 15 years' time that we have got patients putting in the data that we think is really kind of helps to define their needs, that they are able to do that themselves and supported to do it, that we've got a primary care workforce that knows how to look at that data and then to make decisions together with the patient as to what interventions are required, with then specialists supporting primary care with the more advanced kind of decision making and kind of use of new technologies to be able to deliver outcomes that matter to people. And I think that really does require that integration across community, primary, secondary care, together with the voluntary sector, which we've not mentioned yet, who do a huge amount of work out there, and the informal care sector that you mentioned, those families who do so much of this work that we don't even, recognize. So I would hope that it was integrated across those kinds of boundaries. And I would hope that we'd have integration between health and social care, because it is very difficult disentangling health and social care needs for people as they get older. But I think we've got loads of opportunities to do that.
It's funny, as I'm asking that question, I'm like, well, hold on a minute. In 15 years' time, I'm going to be 65 plus. So I just want some clues in terms of what's in line, what's in line for me, hopefully. And so it's quite interesting because there's you talk a lot of that is systemic, though, isn't it? Because it's not a technology, like connecting social care and healthcare is not. I mean, a technology could enable, but there has to be some decision
That's right.
that are made and some changes that are made for that to work in that way. I guess that's where the policy work that you're doing is really quite critical as well. I suppose when I was in answering the question and imagining, I'm thinking about, well, I've probably got some. Hopefully, I'm very fit and healthy at 65. But I would be hoping that there's probably some technologies around, some wearables that are being a bit more proactive, both in gathering data on my condition or also recommending things for me or informing the people around me that I need help. I would hope that with this data, if I have it as an individual and it's something that's more mainstream and it's crossing healthcare and social care, that we would have a very rich data set which we would be able to interpret and find areas of improvement and act on them, and then the evidence-based, not clinically trial based. Sorry, not to be down on clinical trials, but be based on kind of real world kind of data, and actions would come off the back of that. So I guess you would hope for kind of more rapid improvements that are kind of fact-based. We would hope for AI tools or analytical tools to be able to interpret that data in a really kind of quick way. Sorry, I'm like, I'm just sort of imagining a little bit. Does that, like, I guess that doesn't feel that science fiction, right? It feels quite viable.
No, I think it's absolutely doable. But I think kind of, you've really highlighted the fact that we do need policy to be able to inform this. And then we've got to use our enablers to be able to deliver it. And certainly kind of AI and technologies are kind of going to be absolutely a critical part of that. And it's just how we work together across the different sectors to be able to make that a reality.
And just on that question, what are the, like, what are the sort of the headwinds and the tailwinds there? What are the things that you feel that are pushing us in the right way? And sorry, now I'm explaining what a headwind and a tailwind is, but I'll say it anyway. But like, what are the things that are kind of pushing us in the right, you feel that are pushing us in the right direction, and the things that are kind of stopping us a little bit, or we need to work on?
So I think things that are pushing us in the right way probably include the recognition now of what population we really need to support, which population we really need to support with moving this forward. And there's certainly been a change in the last 5 to 10 years where we've recognized that we can't just keep on talking about the changing demographics. We've actually got to do something about that. And so I think that policy change is starting to happen, but we need that to be more consistent. But certainly, like having our chief medical officer, kind of Chris Whitty, talking about the aging population in pretty much every report he publishes is a real move forward. So I think that's a really good kind of tailwind to have behind us. I think, of course, the opportunities being raised by kind of all the new exciting technologies and things are a tailwind as well. But we've just got to, again, use that tailwind effectively and not go off course in the wrong direction with that wind pushing us in a different way. So we need to keep that direction. I think the challenges are the usual kinds of things, really, aren't they? About kind of how do we bring people together from those different sectors? How do we get people to collaborate effectively? How do we stop people being territorial about
Mm.
things and saying, actually, this is my job or your job, and not coming together around it? Of course, it often requires some investment funding as well to be able to kickstart things. So, the challenges, of course, in the healthcare sector at the moment kind of do relate to that. It's around integration and the cultural change that's required. It's around funding and moving money from one sector to a different sector. So not necessarily always needing more money, but actually using it differently. And then it's the workforce and making sure that we're actually developing a workforce which is educated and trained to support the group of people that we're going to need to support into the future, which are older people.
It feels very encouraging, doesn't it? That like we're at a point in time where technology and our understanding of what it can do and the needs seem to be lined up. So part of the reason for doing this podcast is to kind of raise the profile of these really important topics where we can shape a really bright future, and it kind of needs a lot of different people to come together. Like health is a bit of a team sport, isn't it?
Definitely.
And so you kind of need people from all different disciplines to sort of come together and kind of work together to create really great outcomes. And I feel in this space we can. So it's really there's a lot to do, but it's really exciting as well. Jugdeep, thank you so much for the conversation. It's been really fascinating. I really appreciate it.
Oh, no, I've really enjoyed it. Thanks very much, Dominic.
Okay, thank you.